everyone. We are very happy to be here, to be invited again for another talk here. And we thought, since ADHD is a quite common disorder in children and adolescents and adults, of course, we thought this is a great topic to discuss today together with you. So, first of all, I would like to just generally talk a bit about conditions that a child psychiatrist can see, because often we are asked the question, like, what is actually the difference, what a psychologist is doing and what a psychiatrist is doing. So I just want to briefly talk about the conditions we can see, and then Rama, if you want to, you can add what you can see on top of what I mentioned for my area of expertise. Somehow this is not loading. Okay, so basically, as we said, the topic today is about ADHD or ADD. ADD is the same, just without the hyperactivity component. This is one of the most common challenges we see in the clinic when we work with children and adolescents. So we also see cases of depression, which is also quite frequently, I would say, minimum 40 to 50% of our patients, I would say, suffer from depressive symptoms as well. Same amount probably as valid for anxiety disorders and phobias. So almost all the children we see during our consultations suffer to some extent from an elevated level of fear, or any kind of specific phobias of animals or social situations. Then what I do see as well is obsessive compulsive disorders, when the patients have recurrent intrusive thoughts or repetitive behaviors, which are very torturing to the children, so definitely an important topic. Then eating disorders we can see as well. Also often, and we are happy about seeing that tendency to see cases of disordered eating only, where we have the feeling that mommies show up, or fathers as well, and tell us, we do see that our child, once she became a teenager, she started starving, she started skipping meals, or they want to lose weight due to related body image issues. So this is a very common thing we see, and we are happy when the kids show up quite early, because this gives us, of course, more therapeutic options, and also to work on a more preventive basis. Then what I can see as a doctor as well is Tourette syndrome. This is a combination of ongoing motor and vocal tics, or intermittent tic disorders as well. So a lot of children during their early childhood years or later in life, they struggle to some extent from temporary tics. They come especially up in phases where the child shows an elevated level of stress, for example, so that is quite common as well. Then what we do see as well are so-called adjustment disorders. These are basically reactions to adverse life events, and that can be related to a variety of different reasons. For example, expats moving to Dubai, the kids struggling with homesickness or settling in a new city, the parents going through divorce, kids getting bullied in school, a bereavement in the family, or, as I said, moving countries. So what we do see as well are autism spectrum disorders. Also a lot of patients, I think, we see struggle with ASD. Then recently we have a few cases of bedwetting as well. We noticed that this is quite common at the moment. So we have different types. We have the one where the child was never dry and continues to bedwet after the age of 5 years, and then we have bedwetting types where the child was dry for a while, and then a traumatic or stressful life event is happening, and they start bedwetting again. Then we do see a lot of disruptive disorders with social difficulties, where the children show aggressive behaviors, verbal, physical aggression, which makes it difficult to interact with their peers or their families at home. Then we do see relationship problems, family conflicts, where we do have the feeling that more the challenge lies on the parental level, that parents say, like, we have a lot of fights with each other as a couple, and our child starts displaying symptoms of aggression or sadness or disrupted sleeping patterns as well. Then we would focus more on working with the parents in order to sort that out. Then we do see cases of school refusal quite frequently. Can be two different things behind that, either school phobia, where the reason for the school refusal lies in the school setting, that the child, for example, tells us, I'm scared, I'm bullied there, or I have test anxiety and exams are coming up, I don't want to go there. Or the other situation is when a child has a separation anxiety. That means being separated from the parent, especially in the drop-off situation. They get tantrums. You probably often see that outside in front of a school. We hear that very often, that the mommy say, God, I'm so embarrassed. He's throwing a big tantrum right in front of the school and all the other parents are staring at me. So this is probably a case then of separation anxiety, where the child is basically not worried about the school attendance as such, but being separated from the parent while being in school. Then, of course, we can see cases when families have lost a loved one or go through challenging phases and the kids grieve. We can help them with grieving support. And what we also do see are attachment disorders. So attachment disorders are difficulties in forming a close bond with the primary attachment figure. That can be the case when a mother suffered after the delivery, for example, from postpartum depression, and just didn't form a close emotional bond with her child, and the child does not feel the social interaction the way it should be. Then they can display similar symptoms like a child with autism spectrum disorder. They have difficulties with social interaction and communication. Yeah, so attachment disorders are quite common, and we do see a lot of kids who are actually misdiagnosed with an autism spectrum disorder. Turns out at the end, if you follow up on them in the long term, it was more like an attachment disorder, right? Can also happen when parent is traveling often, very busy with work, and then the COVID pandemic came, families were separated for a long time from each other, and then the kids also start showing some social challenges. And this is more likely than an attachment disorder, when the parents say he was fine for 3-4 years, perfectly fine, and suddenly the child showed different behaviors. It can be more related to that one. Whereas in autism spectrum disorder, usually you see this autistic regression after a year or so it starts. But we had one case where it started at the age of 7.
Yeah, at an age.
Yeah. So then, yeah, okay. So what kind of support options do we as a team offer for families and patients? So we do a lot of emotional regulation with the kids, working on validating their feeling, expressing themselves more, finding access to their own feelings, concerns and worries, and be a bit more expressive about that. Then a lot of anxiety management we have to do, which is often quite challenging, because a child with severe anxieties, they always show an avoidant behavior. They do not want to enter the frightening situation. So hence they will do everything to avoid that. But we have to then mildly encourage them and push them a bit to enter the frightening situation, which can result in a lot of resistance towards us doctors and the parents as well. Then we do, while we are doing anxiety management, we also include systematic desensitization. For example, if a child is phobic of a specific situation, like giving presentations, and then we encourage the child, for example, to give more presentations in school, just to overcome that fear and realizing it's not as bad as I was expecting that. Then we do, as I said, if I have the feeling that the family dynamics are contributing for the child not feeling well, we do family therapy or couple therapy for the parents as well. And of course, we are very happy to have wonderful school counselors, pediatricians, and all kind of other categories of therapists on board to offer the child and the families a holistic treatment approach. So, now I hand over to my lovely colleague.
And then we'll talk about medication. So today we're going to focus on one type of neurodevelopmental disorder, which is called ADHD. It's very common, it's prevalent. About 5 to 10% of all children will at some point be diagnosed with ADHD. Now, you may find studies that show higher prevalence rates, lower prevalence rates, but more or less it is around this number. ADHD is characterized by challenges in sustained attention, challenges with controlling the level of activity, with impulsive behaviors, and it will impact other areas of the child's life or the person's life, such as academic performance, performance, social skills, and emotional well-being. So, as I mentioned, it affects about 5 to 7%, which means that in every classroom you are likely to find 1 or 2 students who probably have ADHD at a different severity or a different intensity. Based on the DSM-5 criteria of diagnosis, ADHD requires a comprehensive evaluation. And when we say comprehensive, we mean a full educational psychology or neuropsychological evaluation. And why is that? Simply because a lot of the symptoms of ADHD may be the result of other contributing factors, such as depression. A child who has a low mood or has a drop in motivation is also likely to show a lot of distractibility or challenges with initiating tasks or finishing their schoolwork. Learning problems such as dyslexia, dysgraphia, or dyscalculia, they may also show in the classroom as the child performing lower than expected. If a child has other medical conditions such as hyperthyroidism or hypothyroidism, this is also important for us to clear before giving the diagnosis of ADHD, because a lot of those symptoms can mimic the symptoms of ADHD as well. So when you hear of a child who did a brief consultation with a psychologist or a psychiatrist and who just filled a little questionnaire or just conducted like a short computerized attention test and then was diagnosed with ADHD, then this is one of the red flags that we need to watch out for. This means that the evaluation or the assessment probably was not conducted in a way that is thorough, and that the clinician did not take the time to rule out any other conditions that may be contributing or may be manifesting as ADHD. Subtypes, so we have 3 main subtypes. The first one is called ADHD predominantly inattentive, and this is when the child shows more symptoms of inattention. The second subtype is what we call ADHD predominantly hyperactive/impulsive, and this is a child who will show less symptoms of inattention, but is very overly active, very impulsive, rushes through tasks, maybe speaks or interrupts quite often, cannot wait for their turn, but they have a really good ability to sustain their attention for a prolonged period of time. And then the more common type is ADHD combined, which combines both set of symptoms, symptoms related to inattention and symptoms related to hyperactivity and impulsivity. Causes, yes, ADHD is majorly and mostly genetic. And what we know from studies is that a child who has ADHD, or a parent actually, so a child of parents, if one of the parents have ADHD, then there's a 50% likelihood that the child is going to have ADHD as well. If one of the siblings has ADHD, then there's a 25% chance that another sibling also has ADHD. Environmental factors do contribute to exacerbating the symptoms of ADHD, of course. However, ADHD is mostly inherited and mostly genetic. Symptoms, like we mentioned, they vary in severity as well. So you may find 2 children with ADHD who may have the same subtype of ADHD, but who function completely differently. And this is because the symptoms may be more severe in one of the children than the other child. And treatment, which we will get to more in depth later, is a combination of medication, therapy, and support strategies as well. Today we're focusing also on what we call executive functions. And there are many ways to explain executive functions, and I try to explain it as simply as possible because it can be quite overwhelming at first for parents to understand what executive functions are. And one of the analogies that I like to use is either the CEO of a company or the conductor of an orchestra. And so executive functions, basically, they will help all the different functions of the brain, whether related to attention, language, memory, stored information, reading, writing, math, behavior, impulse control, all the functions that the brain can do, and they will organize these functions in a way that is efficient and that helps us do what we need to do. So it's almost like the conductor of an orchestra trying to organize what each of the musicians is playing or what each instrument is going to play, so that at the end of that group of musicians, we have a nice musical piece, and the outcome looks nice and neat and organized. Executive functions, they're cognitive processes related to self-regulation, organization, planning, decision-making, and like I said, they're like the CEO of the brain, overseeing and coordinating various tasks. And children with ADHD will often show challenges in executive functions simply because the area of the brain that is affected by ADHD is the same area of the brain that is responsible for executive functions. And this area is what we call yes, very good. So the prefrontal cortex. The prefrontal cortex is the area of the brain that is right before the forehead. It is the most advanced and developed area in the brain, and it continues to develop up until the age. So parents ask me sometimes, so when is it going to fully develop? And I say, maybe when we're 50, I don't know. But actually the true answer is in our late 20s. So it's only until the child becomes a young adult that they have fully developed their prefrontal cortex, so that they can actually conduct or they can perform the tasks that require executive functions. So you can only imagine that a child with ADHD is going to struggle with their executive functions, right? So they're going to struggle with going through or performing tasks that require higher order cognitive skills. What would this look like in the classroom? This is a child who's really good in reading, writing, and math. So they've never had challenges with spelling or orthography. They acquired letters and sound, typically like other children, but then they reach grade 6 or grade 7, and now they're struggling to write essays. Why is that? Because essays require a lot of organization, a lot of planning. I have a lot of thoughts that I want to put down on paper, and I don't know where to start. How do I begin? How do I make my essay flow? How do I make it clear to the reader what it is that I'm trying to say? So all those functions are related to executive functions. Another example would be math word problems. This is a child who has never had problems with acquiring their math facts. They did well in their early years in elementary school, and then now they reach middle school, and now they're struggling so much with math word problems. And why is that? It is not because the child has a specific learning disorder in math, because they never showed challenges in acquiring the basic skills related to math, like math concepts, comparing quantities, estimating time, estimating duration or distances. But today in grade 6 or grade 7, they're struggling so much with math, and this is because math word problems and in higher grades, it starts to rely so much on organizing information, extracting the important information from the word problem, knowing which calculation or which equation do they need to use that they've learned in class so that they can solve the word problem that is on the test. And you can only imagine how overwhelming this may be for a child who has ADHD, because it puts a strain on their executive functions and on their attentional capacities. So it is not unusual to diagnose ADHD at an older age. Very often parents will ask, but if they have ADHD, wouldn't have they shown the symptoms much earlier? And our answer is always yes. However, yes, you're right, ADHD is a neurodevelopmental disorder, which means it is brain-based, which means it is genetic and mostly inherited. However, sometimes it is only until the demands of the environment and the academic demands start to exceed the child's attentional capacities and executive functions that the symptoms begin to flare and the symptoms become more obvious. And this is why sometimes we diagnose ADHD in grade 9 or grade 10 when students feel really overwhelmed, they're not on top of their schoolwork, they're missing deadlines, procrastinating, their motivation has dropped so much that they don't even want to go to school anymore. And they're reconsidering school and going like, maybe this is not for me. So this is not unusual. If you do notice, or if you know a child or have a child who is at this age and who's starting to show these signs, then it may be time to seek support or to look more into this. Now the good news is that we can teach executive functions, right? So executive functions, although they come naturally to a lot of students, they may not come naturally to students with ADHD. But the great news is that we can teach executive functions through what we call study skills. And these are the skill sets of executive functions that are mostly related to academic work. And here I'm going to go over some skill sets just to walk you through the kind of work that we would do with a student who has ADHD and who's struggling academically. So study skills are a set of skills that spill into different areas of functioning, such as attention, metacognition, so knowing what I know, helping the child remember what they know or what they have studied already so that they know how to use it and implement it. It also helps with time management, prioritizing, setting a study plan or review plan for their tests, and the purpose of teaching study skills is to help students learn smarter, work smarter, and not work harder. So students acquire the attitudes, the knowledge, the skills that contribute to effective learning in school, and then be able to transfer these skills across the lifespan to university years or even to their careers in the future. First, what we do is we go through a study skills checklist. It can look like this, it can look like other checklists. This is just an example that I found on the internet and that I use sometimes, but it can also look like an interview with the student where we go like, so tell me about your study habits. What time do you come back from school? What is the first thing you do? Do you rest first? Do you set up your study environment so that it is clear from distractions? Do you have a designated study space where you know where to find your things and you don't need to move from your desk every now and then to grab something? Is it comfortable? Is the lighting clear? Is it noise-free? And then we ask about how long do they study for. If a student tells me, oh, I study for a stretch of 2 or 3 hours and then I take 10 minutes break, this is when I go like, okay, maybe this is not the right way to or not the right way to organize your time, because most likely towards the end of those 3 hours, the child is no longer focused or no longer really retaining information at an efficient rate. And this is because they're tired or their brain is drained and exhausted. And so we always recommend then shorter study stretches that are separated by little 10 minutes break so that the brain has time to recharge, to pick up, and to be able to retain information effectively. One skill set is what we call organizational skills, and this is where we focus on creating visual timetables. So some children will say, I prefer things, I'm a visual learner, so I prefer that things are clearly set out in front of me, that I know my study schedule, what it's going to look like. And then others may say, no, I feel really overwhelmed when I have like a visual timetable with colors and details on the paper. So then we accommodate based on their interests and what they're comfortable with. Task checklists, folders and binders, digital tools. There's plenty of digital tools that children can use, especially teenagers who are glued to their screen. And I always say, have you ever used Siri to remind you to do things? And they go like, no. You can use Siri, you can ask Siri to remind you to do something. And I say, yeah, you just, so that it doesn't slip your mind, so that you don't forget about it. Just tell Siri, remind me in half an hour to start doing my homework, for example. Or Siri, remind me to email my teacher and ask about this or that. There's a lot of technological tools that students can use to their advantages that help them navigate everyday life's demands. Establishing routines and workspace setup. So like I mentioned, keeping the study area tidy with the necessary supplies. This is another set of skills as well for organization that helps children with organization. I found it on the internet. There's plenty more, but the idea is to find out or to understand and identify from the student where the deficit in their organizational skills lie, so that we can supplement and help them give the tools and have the tools so that they can study more efficiently. Time management skills. So children with ADHD often have a poor sense of time. They may say something like, I'm sure that this exercise is going to take me just 10 minutes to finish, whereas in fact, it requires a good 40 minutes. But they sometimes have trouble estimating how much time things may take them. And they may do the opposite or go like, this is going to take me a really long time, when in fact it should be done much earlier. So time management is a skill, it isn't a skill that relies heavily on executive functions, which is why we find that children with ADHD will struggle in organizing their time effectively and efficiently. And this is why they're late to deadlines. This is why they require more time and extra time on tests. It is not because they get special treatment, but it's because we're trying to level the field for them, and it's only fair that we give them extra time on tests, because a child with ADHD is most likely going to get distracted while doing their test or while doing a task in the classroom. And so in order for us to help them showcase their knowledge and what they know and answer the questions accurately, we don't want them to compromise accuracy for speed, right? So we want to give them that extra time so that we can level the field for them. Another set of skills also that help with planning and time management. Timers helps a lot, or a visual depiction of time passing helps a lot of students, especially the younger ones, when they see time pass either using a sand clock or on the iPad. You'll find lots and lots of apps that provide a visual depiction of time elapsing, and that helps children know how much time is left and what is left for them to do. Note-taking. Note-taking is a skill that a lot of students will find challenging, especially if they have ADHD or if they have challenges with executive functions. And this is because note-taking relies on many cognitive skills at once. Listening, verbal comprehension, working memory, because we expect the child to retain that information in their mind for a short period of time. Executive functions, because the child needs to filter out what important information is there, and then what do I need to note down on paper. A child or a student who is writing down everything they hear in the classroom is exhausting themselves, right? And it's not helpful for them to go home, read through pages and pages of notes, because they don't know exactly what are the key messages or the key points that they need to focus on. So we do a lot of practice with note-taking. And what I do sometimes is I will then read a paragraph or a passage, and then the child will practice taking notes with me. And then we learn note-taking strategies like either concept maps or the Cornell method for note-taking to help them organize their notes in a way that makes it easy for them to review from when it's time for them to review for the test. Memorization techniques as well. So a lot of children will find memorization challenging, not because they have a poor memory, but because they have poor attention skills. And when a child says, I can't remember anything that was said in the classroom, this is not because they, we don't expect little children to have poor memory. They're not in their late 60s or 70s for them to start experiencing these cognitive deteriorations or impairments. Children have good memory. However, when the child is not focusing in the classroom, when they're not paying enough attention in the classroom, this is when the information is not sticking. So they're not really storing and encoding that information and storing it for future use. And so when your child tells you, I can't remember anything that happened today in class, or I can't remember what the lesson was about, this is because they were probably not paying enough attention. So we help them a lot with memorization techniques. How to remember information in chunks. How to create mnemonics so that they remember the information when they're studying during the test. How to make learning more multisensory and also include a lot of visualization techniques, or being able to visualize information that they're learning, creating movies from, for example, a history chapter. This has helped a lot of students I work with when I go like, okay, so we're going to bring that history chapter, we'll read it together, and then let us picture a little bit what the persons look like, what they're doing. Where do you picture them sitting? Can you describe what the setup or the room looks like to me? And so when we involve all those additional sensory experiences, the memory is stored in a much more efficient way. Goal setting. So goal setting helps the student know what it is that they're studying towards, or what do they plan to finish in the study session. When it's time for the child to do their homework, they open their laptop and they go like, okay, where do I begin? Where do I start? And what do I need to finish today? And sometimes the goal seems really overwhelming, like start researching this topic. And the student goes like, I don't know where to start. And this is where we help them break down large goals into smaller steps, or shorter steps that are time-bound, that are clear and defined, so that tasks don't feel overwhelming. Self-monitoring and self-regulation, to make sure that we also teach habits that help avoid procrastination or missing deadlines. So knowing how long they still have to finish a task is as well very important. And now that I introduced the skill sets, I'm going again to leave the floor to Dr. Daniela, who's going to talk about what a first consultation looks like, and then how we can embed both therapy and medication in order to support children with ADHD.
So why I included this slide, because I find it extremely important, or we often realize during consultations that parents say, we were so scared actually to come to you because we are worried that you would label our child with something, or that you tell us we are bad parents, or we failed in supporting the child properly. And we really do want to take this concern away from you, right? And we want you to feel comfortable to make the decision. We have some challenges at the moment, and we feel the time is right to go and consult a professional for that, without the fear of being judged, labeled, or whatever, because this is where it often fails, making this first important step to say, we think we cannot handle this by ourselves anymore. We have reached a level where we need some advice, and we feel comfortable in doing that. So what we do is, when you reach out to a mental health professional, I think all the colleagues in Dubai do that as well, we schedule a full 1 hour for you to get to know you and to have enough time to revise medical reports that you might bring in, or lab results, or the giving us the feedback what your pediatrician or the teachers of your child have told you so far, right? So you can choose. Colleagues handle it differently. I know a lot of colleagues all over Dubai, they say we want to first make a parent session only, to speak to the parents separately, and then another session with the children. Absolutely okay to do that. I give the parents the choice. I say, make what makes you feel more comfortable. If you have the feeling you can talk more freely about the challenges of your child without them feeling bad about hearing all that, then you can come in alone, and we schedule a second session. But I know time is precious, especially as a working mom. You all struggle with not having enough time. So some say, I want to come in straight away, and that's also okay, right? If you do that, if you decide to go for the second option, bring your child in, I think it's important then that the kids are informed to a minimum of what to expect, that there's a bit of transparency, because sometimes, especially the older ones, they are brought in and the parents tell them up front, you just meet a friend of mommy, that's fine, you just talk a bit how life is going, and then it's difficult for us, how shall we justify why I want to refer them, for example, to Rama for an assessment, and they say, hey, I thought mom, she's just a friend, right? So I think especially with the older ones, there should be a minimum of transparency, that they know what to expect, especially since teenagers are by nature a bit suspicious about everything, especially when it comes to doctor visits as well, right? Then important for us is that you bring in all the important documents that you have collected about your child's development, early development, pediatric challenges, previous disorders, illnesses, or whatever, so that we can review them together. And then we will speak about the early childhood, the pregnancy, delivery, how did you experience that, and then we really start from kindergarten up to the grade where your child is currently at, and we are talking about contributing environmental factors, which Rama mentioned previously, which could also contribute for a child experiencing focusing issues, for example, a bereavement case in the family that causes the child to be sad and then starts having focusing issues. This is very likely related to the bereavement than these focusing issues, and not to an executive functioning or ADHD symptomatic. However, as Rama said, it can exacerbate, right? A child can cope for some time quite well with it, and then another environmental factor adds on top of that, and then the child decompensates, right? We sometimes see that as well. So, and then together we plan the next diagnostic and therapeutic steps. At any time of the process, you are involved in the decision making, right? We will not tell you this is the way you go, take it or leave it. It's very important for us that you as a family and as a parent feel comfortable that whatever decision we make, the therapeutic journey we want to take together, that you feel comfortable with that, right? So, and then based on the results and the discussion on that day, we will design a tailored plan individually for your child and speak about support options. Let's take some time to load.
Yes, I think you just need to. And then I go back.
Okay.
Yeah.
So, okay, so since I'm a psychiatrist, I want to talk a bit about potential support options with a medication for ADHD. And I know whenever I raise that topic during the consultations, I see that scared look in the parent's face, like, oh God, now she's trying to push us to start a medication or whatever. That is, of course, not the case, right? I just want to give you a heads up about therapeutic options from a holistic perspective. Rama was talking about the brilliant psychological support options, but of course, we want you as parents to be educated about all the options that are available to the best knowledge, evidence-based for your child. And then at the end, you can decide what makes you as a parent feel the most comfortable way to go for at first. And we can reevaluate it at a later stage again, right? If you say we tried first one thing, didn't work well, you come back another few weeks later and we rediscuss it, right? So, but medication can be a very powerful and very good option to support kids. Most of the ADHD medications, one of the most common ones, methylphenidate, is on the market since 1954. So this is this year 7 decades, right? So this is one of the best researched medications. We are aware of potential long-term side effects or the potential daily side effects. So we have a lot of experience with that. So the medication generally can be started by the age of 6 years, because that is usually also the time deadline that we set where we start diagnosing kids with ADHD. So if a child shows symptoms of hyperactivity or impulsivity during toddler age, 3 years old, we would not diagnose them with ADHD. We might sometimes in severe cases say we tend to say we see some traits, but a lot of them outgrow till they are 6. But it's totally normal for a 3-year-old to run around the classroom and not sit still and being easily distracted. For a 3-year-old, that's totally normal. There's nothing pathological about that. But if they are 6 and it continues to be a big challenge, then we have to figure out why is that the case. So in case we assess a child at the age of 6, we diagnose it with them, and parents are open for medication, then 6 years is the age group where we can start it. The duration of the intake, this is one of the most common questions as well. Like how long does my child has to take that? That completely depends on the severity of symptoms. If someone has a very mild condition, a great school support team, supporting parents, and good coping skills, as a hard and determined person by nature, they can cope with that for a very long time without the need of any intervention. So, but it is important to focus on the severity of symptoms. Then individual coping skills, as I said, super important, support system, and the professional choice at the later stage. So usually, I'm not sure whether you agree, so my experience is that all the kids that are diagnosed and they start taking medicine, that they benefit from the medication till they graduate from school. Because every year the academic demands are increasing, right? Grade 5 is not as challenging regarding the workload as grade 12, or when they know they are close to finish school and to graduate and to apply for university. There the emotional pressure is coming on top of that as well, right? So usually this also deteriorates the symptomatic a bit when the kids know, God, I need to be good in my finals, because if I don't manage to get a certain level of grades, I will not be able to go to my favorite university. university. So they start struggling even a bit more when they're emotionally stressed as well. So that's why we usually have the experience that kids all benefit and want to continue taking the medicine till they graduate from school. And then it entirely depends on the professional choice your child makes for themselves then. Usually students tell us that they find university much easier than regular school, because in school, I hope we don't have a maths teacher here, no offense, maths was a torture to me in school, so I was glad when that was over, right? And then during the med school time you can focus on the subjects that you like, that you're good at, where your talents are lying in, right? So this is usually why it's much easier for the kids, because they focus on their strengths rather than having to go through subjects which are simply not their cup of tea. So, and if they then have a profession at a later stage which requires a lot of attention and sustained attention, for example, being air traffic controller at Dubai airport, you have to hectically coordinate million flight plan changes or whatever, they might need it for a lifetime, even as an adult, or they might benefit from it as an adult as well. But if they become a dolphin trainer at the Royal Atlantis Hotel, just swimming with the dolphins all day, they might never need it again, right? So it really depends on the professional choice at a later stage in life. And we have different categories of medications available, right? That is extremely important to keep in mind, because we have a lot of families coming in saying, I would basically want to try a medication for my child, but my best friend, her child, they gave them an ADHD medication and they had massive side effects. It didn't work well for them at all. We have to keep in mind that might have been a totally different category than the one we would consider for your child. And again, this other child might have a totally different severity, another subtype, not the combined type, but maybe the inattentive type. So all of that plays a role in choosing the right medication. So you cannot compare one case to the other. Everyone is individual. That's why this initial consultation is so important, and as Rama said, to rule out any kind of other comorbidities which could contribute as well to having focusing issues. So an important question always coming up as one of the second or third questions in the session is, does that cause addiction? No. It does not, right? And if you consult Dr. Google, of course they say something different and you find these specific horror stories, but it does not cause addiction. They belong to, some categories of these medicines belong to groups that if you give them as drugs that you can deal with on the black market, like LSD or whatever, they have similar components inside, but in the medicines we prescribe, they have a concentration that is within the therapeutic range. It's too low to cause neither physical nor psychological addiction, right? So it's very important to know. And of course, we do not want that for children. We do not want to treat a child and help them to lose their focusing issues and at the same time make them a drug addict, right? That doesn't make sense. So we have to be very clear about that, because this is one of the most common fears why parents do decide to not go for a medication. And it's just such a pity, because it takes away a great opportunity for the child to be supported. The medications that we prescribe today, they have a very, very low side effect profile. I'll speak to that about a bit more. So we have basically two different groups of medications that we can use for ADHD treatment. We have the stimulants. The most common one you might have heard of is methylphenidate. The most common brand names are Concerta or Ritalin here in the UAE. Concerta is more the long-acting type of the medication, has an effect of up to 10 to 12 hours, depending on the metabolism of the child. And the Ritalin is the short-acting one, has an effect of up to 3 to 4 hours. We can go for that if a child is in primary school. They say, I finished school quite early and I don't have to do any homework or whatever after school. So you can go for the short-acting one. If you have a grade 12 student, they say, I need to study after school as well. I have to prepare myself in the evening for the next day. They might need something with a longer efficacy. Then we have the amphetamine group, also belongs to the group of stimulants. This is in Dubai only available in an inpatient setting, right? So the big hospitals, the big hospital pharmacies, they can prescribe that. Clinics like us working on an outpatient operating basis, we do not have access to that category of medicine. However, as per the guidelines, methylphenidate still continues to be one of the best and one of the first choice treatments. So we do not have the feeling on an outpatient basis here that we have to compromise on the quality of the medication we can prescribe to the patients. The second group are non-stimulants. To mention, there's atomoxetine, the most common brand name you might have heard of is Strattera, and then guanfacine. Again, for guanfacine, again not available on an outpatient basis, only the atomoxetine. So basically in our situations on an outpatient basis, we go for methylphenidate or atomoxetine to support the child, and 99% of the patients are fine with either of these two medications. It happens very rarely that you have, like maybe once in a year, you have a case where you have to refer them to a colleague in the hospital setting to try one of the other categories of medicines. So, other factors which can influence the decision of which medication to choose for your child is, as we said previously, the severity of symptoms. If it's a very mild condition, child is coping well so far, no urgent need to consider a medication. Then the urgency to start the medicine is a very important factor. Why? Because the methylphenidate, which I mentioned first, that has an immediate effect. The child takes the tablet and 30 minutes later you will see a difference, the same day, like a headache tablet. You have the headache, you take it 30 minutes later, it starts showing an effect. The other one, the atomoxetine that I was mentioning before, the Strattera, this one, it takes 6 to 8 weeks to kick in. This is also extremely important to keep in mind. It's a great medicine, but it needs this time frame to kick in. And a lot of families show up telling us, Dr. Danny, we tried everything. We tried the methylphenidate, didn't work. We tried the atomoxetine, didn't work. And then when I ask, how long did you take the atomoxetine? Yeah, a month, and nothing happened, so we stopped it. So my child is a hopeless case, nothing helps. I say, no, it's not. You just didn't take it long enough, or eventually the dosage wasn't high enough. But it's extremely important to always keep in mind the medicine has only a chance to show an effect if the dosage is high enough and if the time frame given was long enough. So very important to keep in mind that this makes a big difference, and hence it makes a difference which one to choose when you come in with a child in May, and we have that often, right? Come in May and the parents tell us, Dr. Danny, next week she has the finals, we need something straight away. I cannot go for the atomoxetine because it takes 2 months to kick in, would be in the holidays then, right? So there's no other option than to try the methylphenidate because that's the only one that kicks in straight away, so very important. Then the mood, of utmost importance when it comes to making the decision, and I think that is the reason why we read so many horror stories in the internet about certain ADHD medications. Why? When a child has a mood instability, low mood, anxieties, depression, whatever, the methylphenidate is not necessarily a good idea. Why? Because the methylphenidate can make pre-existing emotional conditions worse. This is also a reason why you read so many horror stories on the internet. My child was running around like a zombie. It was not himself anymore, totally changed personality. This was most likely the case when the child was very sad or anxious up front and the methylphenidate was given, which can make mood instabilities worse. If I hear that this is the case, I would educate the parents about in that case, and if you have time, if you don't have the urgency with upcoming exams next week, I would recommend them try the Strattera because that one helps the mood. It is an ADHD medication, but at the same time belongs to the group of mood stabilizers. So whenever a child has ADHD with comorbid emotional challenges, anxieties, sadness, Strattera is the better choice because it treats the ADHD and the emotional symptoms. If I give a child with mood instabilities, the Concerta, it only treats the ADHD, does nothing for the mood, right? So it's very important that mood is always a very important factor to consider. Then the weight. Weight is a problem. Why is weight a problem when we give a medication? Because Concerta, the methylphenidate, is typically causing two very common side effects. Poor sleep, difficulties to fall asleep, because we are more alerted, we are super focused when we take such a category of medicine, so it takes us longer in the evening to unwind and to fall asleep, right? So that's why poor sleep is one. And the other thing that almost all the kids with methylphenidate struggle from is poor appetite. It lasts just throughout the day while the medicine has an effect. So most of the kids, they still eat normally for breakfast, but then they almost want to skip lunch entirely. And then in the evening, when that medication effect wears off, then they eat double the portion for dinner. So usually the weight stays stable. But if I have a child with severe underweight or close to develop an eating disorder, and I give that child a medicine that lowers their appetite throughout the whole day, I can push a child into an eating disorder. That is also a horror story that you can read on the net. But there the medication was just not chosen correctly. You cannot give a child with a very low weight, very skinny, you cannot give them a medication that takes away the appetite very commonly. You have to go for the other one then. Right? Eating habits relate to the weight problem that I just mentioned. Then sleep quality, of course. If a mother says, Dr. Denny, my whole life my child struggled to sleep, we tried all the sleep strategies under the moon to make my child sleep, I will not compromise on the sleeping quality. So then we know already from the start methylphenidate is out, because that will most likely make the sleep quality worse. Then of course allergies. If a child is allergic to one of the components of the medicine, we cannot give it. And the needed time span of efficacy. So Strattera needs to build up in the blood first, but then it's there 24/7. So your child can then focus well all the time, the whole day, it doesn't matter when. Concerta, as I said, has an effect of up to 10 to 12 hours, so in the evening the effect wears off and is gone. So that's why we need to make sure how long does the child need to study. A primary school student, for them it's totally okay to go for the short-acting ones, they don't need something 24/7, but if an elder child says, I need to study in the evening, we need to consider that as well. So before a medication can be started, I know from a lot of colleagues that do not necessarily do that, but I'm following the European standards and guidelines, and in Europe it's definitely recommended to go for an electrocardiogram up front, because methylphenidate can sometimes affect the heart rhythm. So if a child would suffer from an unknown heart rhythm issue that we are not aware of yet, because usually a child never had an electrocardiogram in their life, so we simply can't know. So if we would give a child a medicine that can affect the heart rhythm and they have a heart rhythm issue, that could be potentially dangerous, right? So that's why I always say go for a routine electrocardiogram. Can be done usually with the regular pediatrician, takes 10 seconds, is pain-free, so not a problem. And then we also recommend a blood test with a general profile of all the blood parameters, including liver and kidney parameters, but also very important, like Rama said before, iron, vitamin D, and thyroid level is very important to check on, because if a child has a thyroid problematic or a very low iron level, kids, teenies with heavy periods might experience that. Lack of vitamin D, according to a study of Dubai Health Authority, 99% of Dubai's population have a lack of vitamin D, which causes focusing issues as well. So I saw kids significantly recovering from focusing issues where we were close to having the feeling might be ADHD. We put them on supplements, lifted that, 2 months later they felt significantly better and their focusing issues were gone. So that is extremely important. That's why we also recommend to go for a blood test to rule out physical comorbidities and to make sure a child is physically fit to take the medication. So follow-ups needed during a treatment, yes, there are, of course. So since all the ADHD medications in Dubai are listed either as fully or semi-controlled drugs in Dubai, we have to make sure that we monitor the child properly. The fully controlled drugs, where Concerta and Ritalin belong to, the methylphenidate, we're just allowed to prescribe them for 30 days. So, and the semi-controlled drugs like Strattera, atomoxetine, they can be prescribed for 60 days, which means every 1 month or the other month you have to come and see the prescribing doctor for a brief follow-up. We can handle that very easily, 30 minutes Zoom, and we can send the prescription by email. So because that is for a lot of families a factor as well to make the decision that they say, listen, I'm so busy, I cannot come in every month and take half of a day of work off just to come in to get my prescription. There are definitely ways to get that sorted. Then whenever the child comes in for the prescription refill, when they come to the clinic, and don't do it online, then we check the vital signs as well. Height, weight, and blood pressure is important for us. And every 6 to 12 months, or after each dosage increase, we recommend to repeat the electrocardiogram and blood test just to monitor liver and kidney function and whether everything stays within the desired frame. So the take-home message from my end for today is that medication can be safe and highly effective support option for children and adolescents. However, I want you as a parent to feel comfortable with that decision. If I have a mommy sitting in front of me being too concerned about potential side effect and I feel it would stress her too much to start it, I say, okay, then wait a bit till you feel comfortable with that idea. Go first for the other things you plan to try. Occupational therapy, we totally forgot to mention that. Occupational therapy can be extremely helpful, right, as well. Lifestyle changes, sufficient sleep, reduction of screen time, long sufficient sleep, physical activity, healthy diet, all of that can contribute to improving ADHD symptoms as well. That is important, and if you want to first try all of these options, totally okay. I would recommend make yourself comfortable with the idea of giving it a try. Otherwise, at that point, it will not make sense to start it, because then your child feels better, but you will feel stressed constantly and worried about the side effects. That doesn't make sense, right? So we wait till you as a family feel comfortable to give it a try. And for the methylphenidate, for example, we usually say a 2 weeks trial is totally sufficient. You do not need to commit to a medicine for the next 5 years, right? We can give it since it kicks in the same day. We always say, give it a 2 weeks trial. If you like what you see, you will be anyways happy to continue. And if you don't like it, at least you can say you have given it a try, right? So, but 2 weeks is not a long time. And 95 to 98% of the patients after that come to the conclusion, I definitely want to continue. I see a huge difference. It helps my child so much. So, but again, the medicine should be chosen very carefully based on the individual case history and medical conditions, right? So just last week I had a child, she has 1 kidney only, right? So we have to adjust the dosage. We just found out because we sent her to the blood test and the kidney function was very bad, so we investigated further and we found out she has just 1 kidney. That makes a difference with the dosage, right? If you need to lower the dosage then if a child has a kidney insufficiency. Again, we would have never found that, wouldn't they have gone for the blood test? Again, another horror story you will read on Google, right? And that brings a very bad reputation to medicines that can overall be very helpful when they are chosen correctly. So the medicines have a very low side effect profile. The atomoxetine, a brand name Strattera that I discussed, usually kids have no side effects at all. Most of them feel absolutely fine. Eventually a bit of a nauseous feeling for the first 3 days of taking that. And with the Concerta and Ritalin, as mentioned before, poor appetite and difficulties to fall asleep. Again, it does not cause addiction. And what Rama said previously, that research constantly shows that the combination of medication and therapy targeting all the challenges of ADHD has the best therapeutic outcome. Yeah. So that's why we are always very grateful to work together in a team where we have experts from different areas on board so that we can discuss it together and make an educated decision in the best interest of your child. Was that the last one?
Yeah, so another take-home message is that it is often the case that parents or families will come to me because, as a psychologist, because they don't want to go to the psychiatrist. And when they tell me, I know my child has ADHD, we've been struggling for a long time with therapies and we don't see improvement or we don't see progress that is as good as expected, then it is also my duty and professional obligation to say, well, I respect your decision, we don't have to take medication, however, I need to tell you up front that with therapy alone, we will continue making progress. However, progress may not be as significant or as apparent as it would be if we combine it with medication. And another thing as well that I'd like to remind parents is children nowadays are very well informed of different disorders. They're on social media, they talk to each other, they ask each other, they know who has ADHD and who doesn't, who's on medication and who's not. And when your child comes to you saying, Mom or Dad, I think I may have something, or I think I may have ADHD, it's important to ask them why do they think that, and then rather than looking it up online or finding sources that may not be trusted, consulting a professional so that you get the answers that are credible and evidence-based as well. And that's it.
So lovely to be here and hope for many other more opportunities.
Thank you, guys.
Stay long.